Welcome back, students, to part 149 of our masterclass. Now, before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Today, we are tackling the executive capstone on the inpatient prospective payment system. We're going to take all those complex source materials we've been studying and synthesize them into one cohesive strategy. We're literally decoding how clinical data translates directly into hospital revenue. Let's get started. Here is our roadmap for today's explainer. First, the anatomy of IPDRG. Second, clinical documentation integrity. Third, the revenue cycle workflow. Fourth, managing claims and denials. And finally, a quick masterclass wrap-up.
All right, let's jump right into Section 1, Anatomy of IPDRG, the absolute foundation of payment.
So, what exactly is a diagnosis-related group, or DRG? At its core, it's a statistical classification system. See, instead of paying a hospital a la carte for every single bandage, every aspirin, or every hour of nursing care individually, Medicare and other payers use this system to group patients together. If patients have similar clinical conditions, they're expected to consume similar resources. This setup allows for a fixed, prospective reimbursement. Basically, you know exactly what you're going to be paid before the patient even discharges. And really, that's the only way a modern hospital can accurately forecast its financial survival.
Now, let's break down how this actually builds into the payment structure. The IPDRG system is kind of like a ladder. It groups diagnoses into three hierarchical tiers based on severity. At the very bottom base level, you have cases without any complications or comorbidities. That gets you the standard baseline payment. But if you add at least one documented CC, you step up to the middle payment tier. And if the clinical narrative manages to capture at least one major complication or comorbidity and MCC, boom, you hit the highest relative weight, which means the highest payment. So your secondary diagnoses completely dictate your final reimbursement.
$2,300. Let that number sink in for a second. That is the exact amount of revenue a hospital loses in our source example if a medical coder misses just one CC. Imagine a patient is admitted for pneumonia and the physician either fails to clearly document their underlying COPD or maybe the coder just misses it. That case instantly drops from a complex pneumonia DRG right down to a simple one. The payment absolutely plummets from $8,500 down to $6,200. A single missed code creates a massive, massive financial ripple effect.
Moving right along to Section 2. Clinical documentation integrity, where precision absolutely matters.
We are essentially walking a financial tightrope here. On one side, you have upcoding. This is when someone assigns codes for a higher reimbursement that just aren't supported by the actual medical record. This is a massive fraud risk, and it directly violates the False Claims Act. But on the exact opposite side, you have undercoding. This is the quiet, invisible financial devastation of a hospital. It happens when vague documentation leads to lower paying codes, which drains revenue and artificially tanks the hospital's case mix index. Your CDI teams exist specifically to find that perfect ethical optimization right between those two extremes.
A huge piece of that ethical optimization puzzle relies on something called the Present on Admission, or POA indicator. It's a simple flag, but it tells the payer whether a diagnosis was already present the moment the patient walked through the hospital doors or if it developed later during their stay. Differentiating pre-existing conditions from hospital-acquired complications is literally absolutely crucial for both compliance and ensuring proper payment.
Let's look at a real-world example of why POA matters so much. Say a patient develops an acute deep vein thrombosis, a DVT, after they're admitted. Now normally, a DVT is a high-weighted MCC, but because the POA indicator here is flagged as N for not present on admission, it immediately gets classified as a hospital-acquired condition, or HAC. Under Medicare rules, an HAC cannot be used to bump up the DRG payment. So what happens? The hospital has to absorb the entire cost of treating that DVT, they face a quality penalty, and they get absolutely zero additional reimbursement. Ouch. So, how do we make sure our documentation is totally airtight? Well, it all comes down to terminology. Words matter. Documenting acute exacerbation of COPD instead of just writing COPD captures the true severity of the patient's state. Specifying the exact status, like saying septic shock instead of just sepsis, acts as a powerful MCC driver. Linking an underlying cause, such as pneumonia due to aspiration, or clearly stating laterality, right, left, bilateral. These might seem like tiny clinical details, but they're exactly what transforms vague notes into compliant, fully reimbursed claims. Which brings us to Section 3, the revenue cycle workflow, tracing the journey from admission to payment.
Think of the revenue cycle management workflow as a chronological life cycle. It kicks off at patient admission, moves into the actual delivery of care and real-time EHR documentation, transitions into the highly critical coding and DRG grouping phase, which then generates the UB04 claim submission, and finally wraps up with payer reimbursement. It's essentially a complex relay race of data.
Now, the most crucial takeaway here is that this workflow is entirely interdependent. The clinical teams, the medical coders, the CDI specialists, and the billing department, they all completely rely on one another. Think about it. If the physician's note is vague, the coder can't assign the right DRG. If the CDI team doesn't catch it and query the physician, the revenue is lost. If the biller submits mismatched revenue codes, the claim gets denied. A breakdown at literally any point in this chain brings cash flow to a grinding halt.
Next up, Section 4, Managing Claims and Denials. This is all about protecting the revenue.
When a high-weight inpatient claim gets denied or downcoded by a payer, it's usually because of one of these common culprits. Maybe the medical necessity for the inpatient stay just wasn't clearly justified. Maybe the clinical documentation was too weak to support the MCC. You could have coding errors like a mismatched diagnosis and procedure. Sometimes POA indicators are missing or invalid, which triggers an automatic rejection, or the revenue codes from the billing department simply didn't align with the clinical codes. When those frustrating denials do happen, having a structured denial management process is your only real lifeline. A successful appeal isn't based on emotion or arguing, it's based purely on objective evidence. You have to compile the complete medical record, provide your exact coding rationale based strictly on official guidelines, and draft a structured appeal letter that lays out the clinical facts perfectly. You are essentially building a watertight legal case for why that specific DRG was correct in the first place.
All right, let's bring it all together in Section 5, our final masterclass wrap-up.
Here are the ultimate takeaways that every single health informatics and RCM professional absolutely must master. First, the MSGRG relative weight literally drives hospital survival. Second, to optimize that weight, your CDI queries must always be non-leading and firmly rooted in clinical evidence. Third, present on admission flags are your best shield against compliance penalties and HAC reductions. Fourth, you need seamless data integration from your EHR directly to your billing system to cut out human error. And finally, cross-functional collaboration is the only proven way to stop those repeat denials.
If you remember absolutely nothing else from this executive capstone, please remember this central mantra. Clinical accuracy equals coding accuracy, which equals financial accuracy. The integrity of the clinical narrative is the ultimate source of truth. You simply cannot have a financially healthy hospital without a clinically accurate medical record. It's really that simple.
Ultimately, navigating the MSDRG system isn't just an exercise in administrative compliance. It is literally about the financial viability of healthcare itself. As coding algorithms get more and more complex and payer scrutiny ramps up, one massive question remains. Are our hospitals truly prepared to bridge the gap between clinical reality and coding accuracy? Or will critical revenue continue to slip through the cracks of vague documentation? Think about that as we head into our final lesson. And remember, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you in part 150 for the grand finale.